cholera outbreak in Nigeria, epidemiology, prevention, and control. As we all know, cholera is a very devastating disease. It's a communicable disease, and it is the Committee on Communicable Disease and Infectious Diseases of the university that organizes this public lecture. We are all welcome. Permit me to invite and introduce the members of the high table before we start the program. I will start with the chairman of this gathering, who is the person of Dr. Muhammad Al-Indami, the Honorable Commissioner of Health, Sokoto State. Sir, you're welcome. Thank you. Next to him is the chief host of this program, who is the Vice Chancellor of the Usman Al-Fodio University, Sokoto, ably represented by the Deputy Vice Chancellor, Admin, who is in person of Professor Ibrahim Magawata. Sir,
the Vice Chancellor is unavailably absent, and I am standing here on his behalf. So I'm going to read his speech verbatim. Wherever I say I'm referring to Professor Lawal Suleiman Bilbis and not Ibrahim Magawata. So please take note. The speech goes as follows. It is indeed a great pleasure for me to be here this morning to represent the Vice Chancellor. I wish to use this opportunity to register the apology of the Vice Chancellor, Professor Lawal Suleiman Bilbis, for being unavoidably absent and unable to join the symposium. He had dearly loved to be part of this important event, but for the fact that he has to attend a meeting and a conference simultaneously to conclude arrangement for kickstarting COVID-19 vaccine research and development by our university and her partners. Thus, the Vice Chancellor has asked me to convey his sincere apology for his inability to be with us. I'm sure right now they are at the TED Fund to conclude the arrangement for the funding of the development of the vaccine research for Lassa fever. At the onset of COVID-19 pandemic, and before it was declared a public health issue of global concern, the Vice Chancellor constituted a committee on one-day sensitization symposium on emerging and reimagined viral infections, case of Lassa fever and COVID-19 on the 12th of February 2020 to enlighten and educate the general public on COVID-19. The symposium, which was a national symposium, which drew speakers across the country from the major stakeholders, alerted the nation of the impending agony that may be associated with the pandemic. In our opinion, the symposium was successful. At the eve of the symposium, the Nigerian Center for Disease Control, NCDC, announced the index case of COVID-19 in Nigeria. Because of the success recorded by the symposium, the committee was transformed into Standing Committee on Infectious Diseases, whose mandate include the enlightenment and education of the public on infectious diseases. And it is the same committee that organized this symposium, that is the Standing Committee on Infectious Diseases, which is a 10-man committee headed by Deputy Vice Chancellor, Research, Innovation and Development, Professor Yusuf Said. In view of the magnitude of the ongoing cholera outbreak in the country and its impact on the community, it became necessary for the committee to organize this symposium to educate the public on the epidemiology of the disease, how to prevent and control the disease, and to chart a course to forestall future occurrence. There is no better time to organize this symposium than now. It is important that as a people, we begin to learn and understand that every nation has her own burden, and that no nation can bear the burden of another. It is therefore important that we begin to carry out our own burden, by ourselves. There are a number of health challenges bedeviling our nation, from diseases such as malaria to Lassa and COVID. It is my belief that we have the requisite technical knowledge and the facilities to face the challenge head on. At Usman Danfodio University, Sokoto, we have decided that we can no longer fold our arms. It is on this basis that we recently reinforced our capacity by managing research and development by upgrading the Directorate of Research, Innovation and Development to the Office of the Deputy Vice Chancellor, with the sole objective of development and advancement of universities' profile in the world-class research. Innovation and research training in an increasing competitive environment. The university is therefore poised to ensure effective partnership and collaboration with local and international funders, industry, and public sector. This is the basis on which the university went into collaboration with the Nigerian Institute for Medical Research, NIM Yaba Lagos, and National Veterinary Vaccine for Lassa Institute, NVRI, VOM, JOS, on the research and development, which is already yielding results. It is our belief that the university can also lead in the production of water filtration facilities and the production of intravenous fluids for mitigating cholera and related diseases. We know certainly how careless our people are. You see, wherever you sight our mosque, that is where you find a urinating environment. And we know how pungent urine is, that ammonical odor. And you are praying and the pungent odor will just be passing by your distance. We know how careless we are. We don't even take care of the environment, talk less, and all these now contributed to the breakout of cholera. Well, I'm not an expert in that field, so I shouldn't go in depth in the discussion. Finally, I wish to sincerely welcome all of us to Usman Danfodio University, and pray that this will give us the opportunity to start discussing on how to move forward. Thank you for listening, and wassalamu alaikum wa rahmatullahi.
Dr. Nura, Dr. Arkilla, Professor Sabi, the Medical Director of Christian Ministry of Health, Dr. Mohammed Shahab Gubil, the Chief Medical Director of Public Hospital Maramoko, Dr.Nuruddeed, and Aliyu, distinguished scholars, Professor Ibrahim, other personalities, gentlemen of the press, Assalamu alaikum. Indeed, I'm one of the, I must say, the happiest person to attend this public lecture for the fact that in the last 4 to 5 months, I've been leading the team that is responding to outbreak of cholera in the state. And we have a share of our experience in their response, and definitely we would have loved as the Ministry of Health to have feedback, and also to have more insight on what has happened, how we have responded, and what we need to do better in the next year. Because severally I have been confronted with questions on how to give commitment on the fact that what has happened this year will not happen again next year. We know it's a difficult one, but I've made that commitment that I will do my best to make sure that the outbreak that we experience this year, I will be more prepared in the year to come, which we still, according to experts and epidemiologists, are still predicting that there could be another wave of outbreak of cholera next year. So I'm very happy to be with you this morning, and also most humbled to chair this important public lecture as one of the, in fact, maybe as I'm not supposed to, because I'm also going to be assessed on how we have responded to cholera in Sokoto State. But I'm humbled to be the chair of this lecture, and I do my best to do that. Then, certainly the timeliness of having this public lecture, it has come at the right time. At the moment, the outbreak of cholera has really gone down in the state. We don't have much active cases, and the very few locations report 1 or 2 cases day in, day out. But I believe we are out of the wood. What we have been praying earlier is for the rains to cease, and I think the rains have gone for good, and we don't no longer have cases. Just maybe not to preempt the speakers, but in summary, I would just like to say that we have identified 3 issues that have aggravated or exacerbated the outbreak of cholera in this year, which is, one of it is open defecation. At this moment of our development, we still have cases of open defecation in all local governments of the state, especially in the rural areas.
On the occasion, the Honorable Commissioner of Health, in person of Dr. Muhammad Ali Nami, permit me to stand on the existing protocol already established. My lecturers, senior colleagues, my colleagues, Assalamu alaikum wa rahmatullah. So my name is Dr.Nuruddeed Aliyu, State Team Lead for CDC AFINET here in Sokoto. AFINET stands for African Field Epidemiology Network, and I am going to briefly discuss an overview of cholera outbreak in Nigeria. So this is the outline of my presentation: introduction, epidemiology, risk factors for increased transmission, case fatality rate and case definition, how to define an outbreak, current cholera outbreak situation in Nigeria, so also in Sokoto, the usual sequence of events, and some of the challenges. By way of introduction, cholera is an acute diarrheal disease that can kill within hours if left untreated. Cholera is an acute diarrheal infection caused by a bacterium, Vibrio cholerae, and it's a key indicator of lack of social development. Anywhere you see cholera, most of the times it's associated with poor socioeconomic status. And the infection is now largely confined to developing countries in the tropics and subtropics. And cholera is essentially a disease of the poor sanitation. Cholera has been linked to consumption of food and water from unsafe sources, mainly due to drinking river water, drinking water from unsafe places, contaminated municipal fire-borne water, or eaten at large gatherings. So the pathogen involved is a bacteria called Vibrio cholerae belonging to serogroups 01 and 0139. And transmission of this bacteria is mainly through polluted water, contaminated food, or personal contact with infected persons. And the incubation period is usually a few hours to 5 days. Incubation period is time interval between when the bacteria enters the body and the first symptoms that will manifest in the affected persons. So this period is usually a few hours to 5 days. Some say between 6 hours, or averagely 2 to 3 hours, patient infected might present with symptoms. The diarrheal illness is as a result of secretion of the cholera toxin by the bacterium. And this cholera toxin has been shown to bind GM1 ganglioside, leading to profoundly increased cyclic AMP, which in turn, this cyclic AMP causes a decrease in the active absorption of sodium and chloride by the villous cells, and at the same time cause an increase in active secretion of chloride by the Krebs cells that clinically manifests as diarrhea, and also electrolyte imbalances that's associated with it. As I have said earlier, cholera is a virulent disease that kills within hours if left untreated. And one thing with the cholera is that both children and adults are not spared. It can affect both children and adults, as we are going to see subsequently. The patient presents with sudden onset of profuse, painless, watery stools. And sometimes it looks like a rice water. It is often called rice water stool. It may or may not accompanied by vomiting. About 75% of patients infected with Vibrio cholerae are asymptomatic, meaning that they don't develop any symptoms, but they have the bacteria. Although the bacteria are present in their stools for almost 14 days after infection. And these bacteria are shed back into their stools and potentially infecting other people that they come across with. They have body bacteria, they don't have symptoms, but they can transmit the bacteria. And in those infected, 80% have mild or moderate symptoms, while 20% are those that will develop acute severe diarrhea with severe dehydration. So these are some of the signs of the cholera patients. They may be apathic and lethargic. They may have sunken eyes, dry mouth, cold, clammy skin or extremities. They may have cosmal breathing, mainly due to lactic acidosis as a result of decreased perfusion. They may have drop in blood pressure. Peripheral pulse is usually rapid, and sometimes the pulse you feel it as very fragile. And urine output may diminish with time if perfusion or hydration is not restored in the body, and subsequently leading into acute renal failure or shock, as the case may be. So what are the risk factors that increase the transmission of cholera in our environment? We have poor socioeconomic environment, mainly due to insufficient water supply, in both the quantity of the water and also the quality of the water. How quality is the water that is available? Poor sanitation and hygienic practices of our populace. High population density, like in cases of refugees or internally displaced persons, may have increased rate of transmission of cholera or increased risk of transmission of bacteria to the populace. Then underlying diseases and conditions, persons with tuberculosis, AIDS, or malnutrition, they tend to have increased transmission when such conditions are available. Then environmental and seasonal factors. Cholera epidemics often start at the end of the dry season or early at the beginning of the rainy season, when water sources are limited or often the ones available are contaminated. So So case fatality rate, the case fatality rate is a function of how well we have done in management of the cases and death averted. So this measures the management of the cases. It may be up to 50% in untreated cases, meaning that if 100 cases are infected with cholera, 50% will die. But if well managed, the case fatality rate can be as low as less than 1%, if well managed. And the case definition, this is how do we identify someone to say that he has a cholera, either during or out of epidemics. So suspected case is any person aged 2 years and above with acute watery diarrhea and severe dehydration, or dying from acute watery diarrhea with or without vomiting. Or in areas where cholera outbreak is declared, like during an outbreak, the case definition is that any person presenting with or from acute watery diarrhea with or without vomiting. While we refer as a confirmed case as a suspected case in which the bacterium Vibrio cholerae is isolated from the food by culture. So what is an outbreak? An outbreak is usually the occurrence of more cases of disease than expected in a given area or among a specific group of people over a particular period of time. So this is when you have this, you have an outbreak. You need to compare with the previous data, how the disease used to behave. So any increase in an incidence, then you refer to as you have an outbreak. Outbreak is also a public health emergency. It is a political emergency. It also refers to as an economic emergency. It is an unusual event and an event requiring rapid action. And it can be termed as surveillance failure, because when you have a good surveillance, it should be able to detect early warning signs so that rapid action can be taken to avert the outbreak. It's also a control failure. When you are not able to control it, then it results into an outbreak. So by way of epidemiology, cholera remains a global threat to public health, and the burden of the cholera is estimated to be 1.3 to 4.0 million cases and 21,000 to 140,000 deaths annually. So this burden, you see, with all this million number of cases that do occur on an annual basis, according to WHO, this represents only 5 to 10% of the actual cases that's on ground. So this type of iceberg reporting is mainly due to poor surveillance systems, inadequate disease notification systems, and there have been 7 pandemics of cholera worldwide, the last of which began in Indonesia in 1961. And cholera can be epidemic or endemic. In the next slide, we'll see how we refer to as an endemic. A cholera endemic area is an area where confirmed cholera cases is detected during the last 3 years with evidence of local transmission. Like malaria in our environment, is this an endemic disease? We tend to have it frequently. Well, a cholera outbreak or epidemic, this outbreak and epidemic are used interchangeably. It can occur in both endemic countries and countries where cholera cases does not regularly occur. And in such cases, if you have one case, it can be referred to as an outbreak because it's not an endemic. Like in the case of Lassa fever, one single case is an outbreak. As I have said earlier, there have been 8 pandemics of cholera worldwide. And during the 19th century, cholera spread across the world from its original reservoir in Bangladesh and West Bengal, and claiming millions of lives. And in Nigeria, the infection is endemic, and outbreaks are not unusual. Historically, Nigeria experiences several cholera outbreaks characterized by high case fatality rates. And this epidemic of 1991 have high number of case fatality rates, which is the highest in the country so far. Even though it has 59,478 cases and 764 deaths. And up to today, this case fatality rate is the highest so far cumulatively in Nigeria. And during the last 2 decades, 3 major epidemics have occurred in Nigeria. We have 1992 outbreak, 1995 to 1996, and 1997 outbreaks. And also, good to note that the 1996 Kano outbreak have 1,384 cases were reported with case fatality rate of 5.3%. And children were the most affected and accounted for 22% of all the cases. And in 2010, from Nigeria to December 2010, Nigeria reported 41,787 cases and 1,716 deaths with case fatality rate of 4.1%, which the cases were reported across 18 states. So the Nigerian update now, as we are today, since January 2021, cholera cases have been reported across about 32 states in Nigeria, and many cases were reported in the northern states. As of the recent update from 4th October, according to weekly report from the NCDC, a total of 88,740 suspected cases, including 3,208 deaths, with case fatality rate of 3.6% were reported. So this is the recent case fatality rate. I believe probably by the end of the month we'll have a recent update in this regard. And of all these suspected cases, age group 5 to 14 years is the most affected age group. And of all the suspected cases, 50% are male and 50% are female, no age sex preponderance. And 3 states, Bauchi, Kano, and Jigawa, account for 48% of all the cases reported in Nigeria, with Bauchi having the highest number of cases, reported 19,451 cases. Kano reported 12,116 cases, and Jigawa, the third, reported 10,763 cases, which account altogether for 48% of all cumulative cases reported in Nigeria. So this is top 10 states cumulative cases. These are the top 10 cases with the highest number of cases, beginning from Bauchi, Kano, Jigawa, Sokoto. We see that Sokoto is the fourth among the list. Katsina, Zamfara, Niger, Kebbi, Yobe, and Kaduna. So these 10 are all in the northern region. And these are all the cases reported. And these 10 states have about 90% of all the cumulative cases reported in Nigeria. All the 32, 31, and FCT reported cases. So this is the epidemiology curve of weekly reported cases. Because these green bars represent the number of cases by weeks, since from the beginning of week 1 in January up to the 30th. And these rates are the mortalities by the weeks at its core. So this is a map of Nigeria showing the distribution of cases by RDT and microscopy of cultural confirmation, with also grading of the number of cases in each region. We can see based on, we have milder states. I think like it's only 3 states that have been reported. And we have light green and dark green, and the dark green based on the number of cases reported. So next slide. Okay, sorry. So these are the trends in dates over the weeks of reporting. So all these are the mortalities that occurred during the outbreak. Even now we see that the outbreak is coming down nationwide. We have a lesser number of cases, a lesser number of mortalities. So Sokoto State current situation. So this is distribution. This is dot map showing distribution of cases by LGA. You see the cases are densely populated in the metropolitan area, Sokoto North, Sokoto South, even though there are a high number of cases in Godabawa, and Ilela, reporting higher number of cases, also in Dengeshuni. So this is also a distribution of cases based on the number of cases reported by each LGA. We say cumulatively about 9,000 plus were reported in the state. The number is the fourth in the country that have higher number of cases. We have LGA with lesser cases, less than 100 cases, areas like Gudu, this Savanduni, and Isa report, and Shagari. These 4 LGAs reported lesser number of cases, less than 100 cases, while areas in yellow reported more than 100 cases. Areas like Tangara, Biji, Silami, Yabo, Tambuwal, Kebi, and the rest reported more than 100 cases. While 3 LGAs reported above 500 cases. Areas like Ilela, Wamako, Dengesh, and Dengeshuni, these LGAs reported more than 500 cases during this outbreak. So this number of cases by age group, we can see that the highest number of cases were among the age group 1 to 10, with 2,079 cases, followed by 11 to 20 years, and the least being the elderly, with this number of 39 cases. So this is a sex distribution of cases by LGA. We see that the GLGA reported males are lesser than female. This light blue referring to female, while this ambagala referred to male. So this is the sex distribution of cases by LGA in all the 23 LGAs that reported cases during this outbreak. Next slide, like this pointer is solving an issue. The ITT, can you, oh, sorry, yeah. So this is the number of deaths and case fatality rate by LGA. You see the less case fatality was 1% in ISA, with only 1%, and the highest case fatality rate was reported in Gada and Vishagari, with 14% and 14% each. While the case fatality, the dates were highlighted in date. This number of cases, while the rate above represents the mortalities in that LG. You see, the least reported cases was in Gudu LG, with about, I think it's 1 or 2 mortalities. So this is the trend in the number of cases from week 1, or from week 31 to 38, and the epidemic peaked at around week 12 and week 13. That's when we have the highest, week 32, sorry, have the highest number of cases reported in this particular week. And the cases now are going down significantly. So the outbreak is coming down. So this is the usual sequence of events, how outbreaks manifest in Nigeria. So usually this is the first case, probably the first case that will have a disease of interest. Detection and reporting will occur around probably 9th or 10th day or 8th day. This is in days, while this one represents the number of cases. So detection and reporting usually occur around this time. Then delay in confirmation will also take some days before the outbreak or disease of interest is confirmed. That confirmation occur like this. And we have another delay in the response to the outbreak. This is the response. When the outbreak is peak, then you see team trying to respond to the ongoing outbreak, and we have only opportunity to avert this number of cases when the outbreak is coming down. So this is the usual sequence of events. But in ideal sequence of event, it should be like the first case as it happened, then by the 4th or by the 5th day, there should be early detection and reporting in this case. Then lab confirmation will follow probably around the 10th day. Then as soon as possible, response within 48 hours should start. And when the response is commenced, you see all these huge epidemic will have been averted, potential cases prevented from having a disease of interest. So this is the ideal sequence. We should tend to have more of early detection, early confirmation, early response, so that potential cases will be prevented from having a cholera outbreak. Which I begin, the subsequent presenter will highlight some of those measures in order to control the outbreak. So some of the challenges for the cholera outbreak is lack of potable drinking water, as highlighted by the Honorable Commissioner. This is a key challenge. Even in the metropolitan area, potable water is usually a challenge. Insecurity in some settlements, limiting access, either reporting or having information with regard to the occurrence of some outbreaks. Open defecation in some settlements is also a challenge, as I highlighted earlier. The poor health-seeking behavior among the populace. When the seeking behavior is poor, you see in a household, one will be infected, but delay in seeking care will risk the other children, other family members to also get that disease of, bacteria, so also coming out with the disease. The inadequate facility infrastructure and cholera commodities for management of patients. For example, ringers like that. At the peak of this outbreak, nationwide there was a challenge of having ringers selected, because even the country is among the controlled drugs that they are not imported but rather produced in Nigeria, and they are not available, and the country runs stock out of ringers selected. Then incomplete and inconsistent reporting is also a challenge. Then inadequate human resource for health, which is not only in Sokoto but all in Nigeria. This is also a key challenge in management, in response, in coordination of activities. So I think these are some of the references. Thank you very much for this thing.